and thank you everyone for joining us for the second of 4 webinars in the 2021 Revenue Cycle Improvement Bootcamp with BKD. I'm Shannon Norman, Program Specialist with the National Rural Health Resource Center. Today's topic is telehealth coding updates impacting reimbursement. The third session is scheduled for Tuesday, January 19th at 11 a.m. Central, and will focus on charge capture improvement and best practices. If you're able to, please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default. To avoid background noise and feedback, please remain muted unless you have a question. To unmute your line, please use the microphone icon in the lower left corner of your screen. If you called in, you can unmute using *6. You can also communicate via the chat box, which is located on the bottom ribbon in the middle of your screen. If you haven't done so already, please take a moment to type your name and organization into the chat box so we know who's joining us today. Next slide, please, Caleb. In addition to the annual Revenue Cycle Improvement Bootcamp, the Center has compiled revenue cycle resources, and a few of those key resources include the Best Practice Concepts in Revenue Cycle Management Guide, and a compilation of tools included in the Rural Hospital Toolkit for transitioning to value-based systems. In addition, following this 4-part series, the program will be offering follow-up one-on-one coaching calls with BKD consultants. Please contact me directly, Shannon Norman, if your staff could use additional assistance with specific coding and billing questions. Next slide, please. And before we jump into the session today, I'd like to just take a moment. We have 2 pre-poll questions. Caleb, if you'd pull those up for us. And the first poll question is, RHC providers will be eligible for distance site telehealth services in 2021. And the second question is, what payment methodology is RHC telehealth paid in 2021? Our speaker today is Marla Dumm, Managing Consultant with BKD. With more than 20 years of experience in the healthcare industry, she provides reimbursement and compliance audit services and education. Her experience is in professional coding, documentation and billing compliance audits, analysis of medical practice charge master description or fee schedule descriptions, CMS 1500 and UB04 claims detail and charge capture review, HCC and clinical documentation analysis, analysis of risk adjustment impact, quality measure analysis, and physician and staff education on coding, billing, and regulatory compliance issues. I'll now turn things over to Marla to get us started. Marla?
Thank you, Shannon, very much. Welcome, everyone, and we're happy to be with you today. Next slide, please. We're going to be talking about telehealth today, and just as another piece of housekeeping, this session has been approved for 1 CEU through the American Health Information Management Association, or AHIMA, and so Shannon will be keeping track of the attendees today. If anyone needs CEUs, we'll send those out. The certificates will go out based on those email addresses after the session. So just wanted to let you know that that CEU was going to be available. Next slide. We're going to just touch base on what we know now on telehealth going forward, which there is still some gray area just because of the public health emergency. So we kind of have our what's happening now and then what may happen after the public health emergency as far as telehealth is concerned. And this really is impactful for all of healthcare, but particularly for the rural health clinic side, given the fact that telehealth services in a great degree were not eligible for that setting prior to COVID. Or the public health emergency. And so that is going to be something that's going to have to be one of the considerations for the RHCs, depending on what occurs after COVID. So we'll touch on some of those considerations. There were not a lot of billing or coding updates in the final rule for telehealth for 2021. It's pretty much status quo. As far as the coding modifiers we use, how we bill, how we're being paid, a lot of that is staying the same until the public health emergency is lifted. But we'll touch on some of the updates that we have from CMS in regards to their list of services. And then there is some adjustment information on the cost sharing for the rural health clinic side on telehealth, so we'll touch base on that. And then really just provide you some talking points that you can perhaps take away in your either forecasting or game planning for our world after COVID. Next slide, please. And the next will be fine. We're going to touch on the CMS updates first. Next slide, please. Oh, thank you. One of the pieces of information that has been a pretty consistent transmittal since March of 2020, when the public health emergency got started, is MLN Matters SE 216. This MLN Matters is specifically for rural health clinics as well as FQHCs. And so we do defer to this often for a lot of our information on telehealth services, how that's going to apply for RHC providers, as well as any impact that may be coming down the line for the reimbursement. So they updated this December of 2020. And in that, they just reiterated a few of the givens that we have right now that are part of the waivers that are put in place for telehealth. The first most important is that rural health clinics will still be eligible to provide those distant site services for telehealth, whether audiovisual or audio only, until the end of the public health emergency. And that public health emergency is updated quarterly. And based on some news stories that are coming out, that public health emergency is now extended to April of 2021. And so we kind of live on a quarterly cycle as to whether the government will keep or continue to issue or extend that public health emergency. So now we're looking at April of 2021. And as long as that governmental decision is in place, all payers will have to still follow suit with working under the waivers, the reimbursement methodology, coding and billing. All of that will be in place until that public health emergency is lifted. The guidance also indicates that really any of your healthcare practitioners working for the RHC may continue to render those services by telehealth or virtual communication, because that is part one of the approved Medicare distant site areas, as long as it is an eligible telehealth service. And we do rely back to CMS on their list of codes that are approved for telehealth services. Any other service that you might render by virtual communication or telehealth would not be eligible for billing unless that service code is on the list. And that list is continually being updated and was updated again for January of 2021. And the link for that list has been provided in the presentation. Next slide. As some of just the background on CMS and telehealth, the updating of the list is not uncommon. As soon as they started rolling out the eligibility to provide telehealth services in 2003, Medicare has kept a very close eye on how they approve services to be done virtually. And as we know, but prior to the public health emergency, that list of services was very limited because a lot of those they still expected to be done in person. And so there is always a comment period or a submission period, usually prior to February of the given year, where providers or facilities can submit ideas for services they would like to see added. And that really picked up during the COVID, where there were multiple services being requested as an addition to that list, given the COVID situation and the way that facilities and practices needed to reduce exposure. So that process has always been in place. It just escalated really as part of the public health emergency. So for 2021, as part of that routine process, they've updated the telehealth list, and really now they're even going into a categorization of services going forward. And I think they're just anticipating the end of COVID, public health emergency, and what will happen after. But right now we have telehealth services listed within categories. And the first category will reflect service codes that are very similar to what we would see as normal practice activities, consultations, office visit, psychiatric services. These are services that we've already seen on the list, even those including sites of service that we had added, such as some of our hospital services, some of our nursing facility professional services that were not uh, 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 on the list before COVID started. Because again, some of those services like hospital, they expected the providers to see that patient face to face. So some of those codes were added as category 1. These are going to be permanent on the list. If that's considered a category 1 service code, that service code will continue to be on the approved list going forward. Next slide. Then we have some services outlined that were added to that category 1. And so these were some of our behavioral health or psychotherapy codes to include group therapy. The one thing that we will note for the rural health clinics on the call is that we don't know or have not seen anything from Medicare saying that rural health clinics are either eligible for or excluded from reporting group therapy via telemedicine. The reason we have that cautionary note is that group therapy or any group services at all have never been allowed in the rural health clinic setting. It always has to be individual psychotherapy that was approved. And so that's a piece of information we just don't have yet as to whether you could start doing Medicare group therapy via telemedicine or not. So wanted to give you that extra piece of information. But there's other information as well, like your assisted living visits that fall under that domicile category, home visits where you go to the patient home or would normally go to the patient home. All of those services have been added, including the prolonged service code, that G2212, which was added for 2021. That's another code that we still have kind of a gray area with Medicare as to whether particularly RHCs will be able to report prolonged services as part of that telemedicine service, or even the face-to-face evaluation and management services. Historically, rural health clinics were not allowed to really use a lot of those add-on codes. They just wanted to see that primary service code, and then anything else that would be additional time just was not eligible to report in the RHC setting for Medicare. And we don't know if the fact that these codes have been added to the list kind of provides an exception to that rule for the RHC side. We are still waiting for transmittals to come out from Medicare with some clarification on some of these items, and that has not been released yet from Medicare. So be watching for that. Then we have category 2 codes, which will be services that are not similar to what is already on the list, but they are being added and they are going to be considered permanent. Next slide, please. Then we have examples of what they've put into a category 3 service list, which will be temporary services. These are things that are considered for telehealth during the public health emergency. They have realized the rationale behind adding those services to the telehealth list. It made sense for the scenarios that we have now, but those will not be permanent going forward. These services would only be eligible for reporting via telemedicine until the public health emergency is lifted. So those are things like our hospital services, some of our home visits are going to be added into that. Emergency room department visits, which were specifically added because of the public health emergency. So you'll see some of these services that we have listed, even critical care, will be removed after the public health emergency because it's going to be expected that those providers are face-to-face with that patient for those types of more services just with a complexity that might require that face-to-face interaction with the patient. So those are the 3 categories, and the list that we have for telehealth now, those are not only with indicators of services that would only be eligible for phone only, services that are available for audio, visual, or phone, and now we have further categorization of those service codes. So we really advocate that this is a resource that your practices and your hospitals need to be aware of and be utilizing actively, so that you are aware of what you can actually perform by telehealth. It's not going to be everything, although the list is getting so large that at this point, a lot of our services are included. Next slide, please. And speaking to what we may be looking forward to after the emergency, I know that some of the commercial and managed care plans, even through the last several months, even as far back as July, were already issuing information that they were wanting to cease coverage for some of those telehealth waiver services, such as the phone only, such as utilizing the fact that the patient could be at home. And because of the public health emergency that has to be really ended by a congressional action, or decision, CMS really alone does not make that decision to lift the public health emergency. And so all of those payers are still very much in line with still requiring the same type of coding and billing as we have been using to date. And all of those rules are still in place until the end of the public health emergency. But having said that, we fully anticipate that after the end of the emergency, there will be a more relaxed requirement, and that a lot of the flexibilities that we have enjoyed and really absorbed into our practices may go away or may be restricted in just another manner. And that includes where the patient can be located, how we bill for that originating site. That's kind of been very flexible based on the fact that there was not a lot of in-person services being done with our patients. Have confirmed that the real-time audiovisual communication requires use of both audio and visual technology. And this is going to be an area that most likely Medicare will also roll to after the emergency. They will reduce, more than likely, the amount of work we can do over an audio-only contact. Now, having said that, especially in the rural environment, we do have a lot of patients who may not have access to internet, but this is where that originating site waiver comes into place. That's why they only opened that home setting to the public health emergency, because otherwise the patient is expected to be in a site where you do have that two-way audio visual, usually internet or computer connection to from the patient to the provider. And that is why that ability to have that patient at home will probably be reduced, if not excluded, after the COVID. They will be required to come into a site that would have that computer access, so that that phone only would not be as much of an issue that would need to be dealt with. The phone only, as we've been saying, the final rule really has been thinking forward and indicated some language that CMS will create yet another G code, which is usually specific to primary Medicare. This would be a 2252 at this point in time. They are saying that this code would potentially be effective after the public health emergency is lifted, and that the definition of that would be 11 to 20-minute audio only call, and that would be allowed for an encounter with the physician or the non-physician practitioner if that patient was not able to have an encounter where they could visualize the patient. So we'll be staying tuned on that. Obviously, that won't come into place until the emergency is lifted, so it's doubtful that we'll have additional instruction until then. But wanted to get that on your radar, that Medicare at least is thinking down the road, knowing that there will be some circumstances where phone only or audio only without that visualization is maybe going to be the only scenario that will work for that particular visit. So keep tuned on that. We also have the guidance about whether you bill a telehealth visit if the patient and the practitioner are in the same location. And that's been guidance throughout this public health emergency. It's just kind of lost under the rug a few times, where people forget about the fact that, for example, if you have the patient in your parking lot and they are calling in and you're having that audio only or maybe a smartphone audio visual visit with the provider who's in the clinic, several yards away in their office, they are on the site of that clinic. So that's not really defined as telemedicine. It's just that they're reducing exposure and the patient is in the parking lot or maybe in another their exam room or for the hospital setting in another part of the hospital, communicating virtually with a provider who is in the same hospital or clinic or in that same area. That's really not technically telemedicine. So you would bill that service just as if the patient was physically in the exam room with the provider. Same as you would in the hospital setting. If it was to have been seen in the emergency room or another outpatient setting, then you would bill that as if you were face to face with the patient. We've had a lot of questions from the hospitals about a patient up on the floor and the provider is down in the emergency room and they're communicating virtually from the room to the emergency room. And is that telehealth? No, that would be considered a round, just a regular rounding visit if they're just communicating with that physician from the floor. So things like that we need to continue to keep in mind because that will be a guidance going forward with any telehealth guidance that we have. That's not technically meeting the definition of telehealth. Medicare is kind of watching that, and I would not be surprised if future audit activities don't include that as something that they'll be looking for. And I know that external and internal audit activities have really been recommended, and we do as well, that your organization really start looking at or asking someone to come in and look at some of your documentation and your coding and billing for telehealth services in anticipation of the fact that payers will be very interested in seeing whether documentation actually supported those services that you were billing during kind of all the chaos and the crisis that we've been dealing with. So keep that in mind as well, that perhaps this will be an area that you'll want to kind of get ahead of or take a look at before the end of the public health emergency. And I do see that we have a typo here on the bottom. I do apologize for that. I did not get that corrected before today, but it should be G2025, which is specific to our RHCs on the phone. We are still waiting for a payment rate for that code, which is that G2025, which is what you are rolling any of your audiovisual or phone only telehealth visit codes to report on that UB04 out to primary Medicare. We do not have that 2021 information yet. The final rule or the fee schedule was dropped last night that had been kind of delayed because of their changes to the conversion factor on the fee for service side. And so a lot of our information as far as dollars have been delayed because of that. But in looking through that data last night, we did not yet see any information about either that G2025 or for those who are billing any chronic care management with that G5011. They have not released any of the G code reimbursement rates for rural health clinic yet. So stay tuned on that. Next slide, please. The G2025, as we've discussed, is the code that your system will report to Medicare. And that code really includes a number of services, really any of the approved telehealth audiovisual services, as well as our phone-only CPT codes, those 99441 through 443. CPT codes. Medicare takes the allowances for those particular service codes and comes up with the average of our reimbursement. The coding of this and the billing will remain the same, where we have that UB04, particularly for our rural health side, where you still use that 521 revenue code. And internally in your system, you're still mapping the actual billed CPT service code to that G2025 to go out. Now, right now we're being paid $92.03. That's the allowance for that service in the RHC setting. That is a fee schedule payment. So regardless that it goes out on the UB04, you're paid fee schedule for that, as a reminder. Another update I wanted to provide to you from a reimbursement perspective is that CMS really in error put into place the cost sharing calculation in place based on our usual and customary RHC patient coinsurance calculation when this first began. So as we all know on the RHC side, your coinsurance for the patient is basically 20% of total charges versus the encounter rate or the amount that you're being paid as far as an allowance, for example. And so Medicare, I think, just automatically rolled that over because it was being paid out to an RHC, then realizing later in the year that they had adjusted that incorrectly. This is a fee schedule paid service. So they have adjusted that reimbursement so that the 20% patient is responsible for is 20% of that allowance for that $92.03. So Medicare would essentially be paying you 80% of that $92.03, and then the patient would be responsible for the 20% that's remaining. Now, there is always that lesser of guidance for Medicare that they'll pay you the lesser of either your charge that you have assigned to that telehealth service or that allowance. So that goes into place as well. If your charge is lower than that $92.03, then they will base their payment on that charge versus the limit cap that they've put for that allowance. Medicare did or said that they would automatically be reprocessing any of those claims for you on the back end. So it may be something that you may not have, noticed in great degree. They were looking at those claim forms that were coming through maybe in November and October and early December of last year. That should have been fixed by now. Because the MACs were going to go back and automatically reprocess that cost sharing portion going forward. So you might have seen some adjustments on your side. Going forward, that new payment methodology and calculation of cost sharing is standard now in their edits, so you should not have any problems into 2021. Next slide, please. And just some additional information on the cost report, of course, with the caveat that I don't do cost reports. I'm not a CPA, but there are some pieces of information that I can share with you. Just our continued, concerns about the counting of visits and all of that for the telehealth. Just as a reminder, CMS at this point was not going to be using the costs for telehealth towards your upcoming RHC all-inclusive rate. And cost report preparing, which, really now your cost report preparers are just probably now getting into a lot of that telehealth data for your most current cost report. So all of this will be kind of new for a lot of you who may have different year ends. But the originating and or distant site telehealth costs would be reported on CMS 2217. They'll be reporting that on line 79 of worksheet A. And that will be under a header for costs other than RHC services, because again, you're being paid fee schedule for this. So your costs are not allowed towards that rate calculation. And any managed care wrap or roundup payments that you may have arranged with your commercial or MCO plans as part of a contractual agreement, those do not apply to any of this telehealth. That's not an encounter rate service, so you would just be paid fee schedule, or should be just paid fee schedule allowance for telehealth services on the commercial and MCO side. Next slide, please. So to finish our discussion today, I wanted to just spend a little bit of time going back through some of the billing and coding just as a refresher. I know that everyone is very fully ensconced into telehealth with the COVID public health emergency. And I know a lot of practices, the volume of services rendered virtually has just escalated because of COVID. And I think going forward, most practices and hospitals will still utilize a pretty good volume of telehealth. It's been an invaluable service to the healthcare industry, knowing that some of that volume will be reversed once patients are really more actively coming into the office. But again, we really have three categories that any of our virtual medical evaluation and management services are being conducted. The first, of course, is the audio visual, which is really truly the definition of a telehealth service, is that two-way audio visual real-time electronic communication between the patient and the physician or the non-physician practitioner. And it's really meant to be a replacement or a substitute for that in-person E&M visit. That is the purpose of that virtual communication. Most of that, and in some payer policies, they require that to be synchronous, and in other words, at the time of the visit. But there are also codes and reimbursement for asynchronous, if that's the case where information may have been sent in prior to the actual visualization visit, and that also falls into that telehealth category. Of course, during our public health emergency, we had that waiver that included the phone only, which again has been invaluable for a lot of the clients we work with who are in the rural or kind of areas of our country where really, first of all, for exposure purposes, they were not coming into the practice or hospital, and or did not have any internet communication at all. And so the phone only option has been invaluable. We also have the e-check category, which is again a patient initiated brief phone call, usually 5 symptoms I am having, and then getting that instruction about next steps. It is not technically an evaluation and management service. That's not the purpose of those e-checks. The purpose is to give those patients maybe almost like a hotline to call in and say, what do I need to do next? And that's been really utilized during COVID to see, do I need to go in and be tested? Do I need to go to the emergency room? Do I need to come into the clinic to be physically examined? They do have that 7-day rule on those kind of e-check triage calls that it cannot be related to any in service that you've rendered in the prior 7 days. And it can also not be billed if it results in a scheduled face-to-face visit within the 24 hours following that call from the patient. So those rules do need to be followed as well. And then we also have that option for digital or portal e-visits or electronic visits. And those are for your organizations on the call today who do have patient portals that are already set up, and they have that ability to communicate, usually through email, often text messaging, but usually email back and forth between the patient and a provider. And again, it's really not an evaluation and management service. It's a communication back and forth, basically to ask questions and what to do maybe next as an action plan. Next slide. Oh, and the next slide. So as some of the reminders on our billing and coding, just to go back through some of our categories that we have for telehealth itself, that audio visual communication, we always have our originating site. That's that HCPCS code Q3014. It's not been used as much during the public health emergency because so many patients were housed in their own home. But again, as a reminder, if that patient is physically located in a healthcare entity and is then calling out to maybe your provider for that distant site professional service, the entity that houses that patient for that visit is the one that bills that originating site or that Q3014. And I know that there have been a lot of issues with figuring out how to bill and having CMS clarify how hospitals are to bill for outpatient provider-based clinics or departments when the patient is at home, but the distant site service is being rendered by their provider-based clinic providers. And that has really been a point of discussion with CMS this entire time. Some of the things we had waivers on was, for telehealth was making sure everyone was in a HIPSA or a medical shortage area. Those restrictions were waived. Being in the patient home has been one of the waivers as well to allow that as really that originating site. And for the rural health clinics, we don't have that option of billing for that Q3014 if our patient is actually in the home. That service is just not billed for that encounter. It's only the hospital provider-based or outpatient clinics that really had that additional option of how they might be able to capture that facility component of that service. Many of the changes that we had really were retroactive back to March 6th. Can you believe it that we've been almost a year now really dealing on the healthcare front with COVID? It's really amazing really to watch that we're almost at a year now. But just as a piece of information for the hospitals, in the most current frequently asked questions that CMS has really been updating, not monthly, but pretty close to monthly, just keeping everybody up to speed. Your hospitals do still have that option of submitting information to Medicare for a temporary extraordinary circumstance relocation exception. That works in some great part to expanding your footprint, but also comes into play if the patient's home is really really considered to be an extension of that outpatient clinic. And depending on the work that's being done, whether it's telehealth and really that Q3014 is more appropriate, or whether either staff is physically going to that patient's home, or whether the service that's being rendered by telemedicine is actually the service that would have been rendered in the clinic, maybe a procedure or maybe some other type of evaluation, that hospital really visit code would be appropriate, especially for Medicare, in putting into place those G codes that would be in place, like the GO436, whether that's appropriate or not. So always just make sure you're checking your guidelines, that you've gone through those steps of, registering the patient and making sure that you've taken those additional steps of submitting that location or that address information to Medicare, if you want that home to be considered really an extension of your provider-based entity. Otherwise, that Q3014 would be appropriate because it would just be a telehealth service in that circumstance. Next slide, please. We've talked a lot about the patient at home. Again, that was a waiver during this time. They issued guidance for that in April, and just some additional bullet points on the hospital scenario, whether the Q34 or 3014 or whether the GO436 would be appropriate. We still don't know on the originating site fee for the Q3014 what our reimbursement will be for 2021. In 2020, it was adjusted and raised even after the final or the fee schedule had been released in January. It was increased to $26.65. So based on the adjustments they'd made to the conversion factor on the fee schedule side, I would expect that we'll have a few more dollars there for 2021 for that Q3014. Next slide, please. Again, our distant site practitioner is the other side of the coin for a telehealth visit, and that's really the professional service that's rendered either over audiovisual or the phone only at this point. And this is just a very brief list of those practitioners that are approved for that. And as we all know, during the COVID public health emergency, CMS has continued to add to that list. This is not an all-inclusive list by any stretch. Obviously, our physical therapy, our OT, our speech therapy, those were added. Dietitians have been added or were on the list initially. There's a lot of maybe more your ancillary outpatient services. Those providers have been added slowly as the public health emergency went on. So as long as it is an eligible practitioner on that list and they are rendering a service that's on the eligible telehealth service list, and they are working under their scope of practice under the appropriate layer of supervision, if applicable, then you are okay to bill for those telehealth services. Next slide, please. We'll step through just very quickly the difference between maybe a Part B professional bill for that denied service, as well as just reminders on the RHC side, just because we're billing on a UB04 for our rural health clinic side. But remember, in usual circumstances for Part B, you'll be billing that telehealth distant site professional service code on a CMS 1500 claim form. This is going to be applicable to a lot of your commercial and MCO plans as well. Again, it has to be an eligible professional service that is on the approved list, and be sure to check those updates that are for 2021 and by an eligible provider. The code that you assign will be the code that's appropriate for the service rendered, and it will mirror, whatever the service actually is, whether it's an evaluation and management service, was it a dietitian service, whatever the appropriate code is for that service is what should be reported. And you'll report the place of service where the service would have been performed. That was a change for Medicare going into the public health emergency, because they want to make sure they're pulling the reimbursement from the appropriate bucket. So instead of billing a typically telehealth place of service like the 02, Medicare wants you to report the place of service for where the patient would have been or is when they get that telehealth service. This was in part because of all the patients that would be in their home. So if your distant site service is really being rendered by a provider in the provider-based clinic, then you would use, and it's on campus, you would use a 22 place of service, for example. If they're calling into the provider that's in the clinic, maybe a freestanding clinic, then you would use place of service 11. 95 modifier would be appended to the service codes, and then you will be paid the appropriate either facility or non-facility fee schedule allowance for that distant site professional service. Next slide. For the phone only, for Part B, fee schedule reimbursement, you are also going to be billing that audio only or phone only telehealth evaluation and management service on the 1500 claim form. But we will not be using the true evaluation and management service codes. You will be using the phone only CPT codes, which are 99441 through 99443, keeping in mind that these are time-based. So even if you have a note that is outlining your SOAP note for the day, our subjective that we had, our history that we took, whatever physical exam elements might have been obtained verbally, and our decision making, that visit needs to have the time documented, because that's what's going to pick your service code for that day, whether it's 5 or 10 minutes or upwards of 20 minutes or over. So be sure that's in your documentation. Again, the place of service will reflect where the patient would have been if they were not in their home setting. And then you are paid under fee schedule for that service. Next slide. Now for the rural health clinic. And I'm only putting up the information that was effective from July 1 on, because remember, we had that little period of time there where there were some hiccups, with our filing, as well as how reimbursement was being paid, because Medicare had not fully updated their systems yet. Hopefully, I am hoping that everyone on the call is not having any issues with the reimbursement of the telehealth services. That should be well in play now with Medicare. But remember that this is going to be considered a professional service, even though paid under fee schedule. Your telehealth service will be reported on your UBO4 claim. Again, it must be an eligible professional service off of the telehealth list and be rendered by an appropriate professional staff in your RHC. The CPT code or HCPCS code that you're assigning initially will be the actual service code. So maybe you're doing a 99213, you would assign the 99213, and internally your system will map that over to the G2025, which is then transmitted to Medicare. At this point in time, you do not put the CG modifier onto that HCPCS code. That is not going to be part of your rural health clinic billing. So you might want to make sure your edits are set up correctly. And then they gave the option of appending modifier 95. It is not mandatory, it's optional. But I know a lot of the RHCs that we work with have been using 95 just as an additional indicator that it was a telehealth visit. And also just for reporting purposes, it's easier for them to maybe pull that data out of their systems with that modifier. And this service is also paid under the rate, the $92.03. And again, we don't know what 2021 will be. Next slide. The phone only is also the same. If you have a phone only service, you will be using the appropriate time-based code 99441 through 99443. And then internally, your system should map that over to, again, that G2025 that will be going forward. And those phone only services are appropriate for either new or established. That was corrected along the lines where it really began as they didn't want that phone only to be done for a new patient. Medicare did not really at that point consider that an adequate use of the phone only for new patients, but that changed over time. So really any of our virtual services can be either new or established patients. Now do keep in mind that those phone only service codes are also held to that 7-day rule, where it cannot be related to a face-to-face or an E&M service in the prior 7 days. And the results of that phone call cannot lead to an in-person E&M service or scheduled appointment within that 24 hours. And if that's the case, then you would not bill for that phone-only visit. And your reimbursement, of course, is at the fee schedule amount for the G2025. Next slide. Just a visualization again of our billing going forward, not only that past billing that we had for any of your old claims that may still be being processed, where we did have to have that CG modifier on it, and then on the visual of what your UBO4 line item would look like going forward from July on, with that optional 95 if the practice chooses to do so. Next slide. Cost sharing, remember that the CS modifier for primary Medicare is still applicable. That's really any fee-for-service service or any RHC service. If it's related to COVID, And the evaluation is for that purpose, is to evaluate COVID or to evaluate for the patient symptoms that could be COVID. Their direction is that it leads to testing or could lead to testing, but really the bulk of that E&M service is for the evaluation of possible or known COVID. So that cost waiving is still in place, and that's applicable to your telehealth E&M service as well. And so wanted to just remind you, hopefully everyone has been using that appropriately to get that cost waive or that cost sharing waiver applied to those dates of service. Okay, next slide. Again, this is still in place where if your providers are still actively working outside of the clinic or the hospital, if they're working from home, maybe a home office, it is still appropriate for them to bill as they would if they were physically inside the appropriate site of service. So if these are RHC or clinic staff and they are working from home instead of being in the RHC or another provider-based clinic setting, then you would bill that telehealth service as if that provider was physically in the clinic. Just wanted to make sure you knew that that waiver was still in action until the end of the public health emergency. Next slide. Again, just some reminders on the virtual check-in. That's that kind of that triage call that is initiated by the patient, not initiated by the practice, the physician, or any other staff. It's a triage for that staff to determine next steps. And on the Part B side, that is billed as a G2010 or a G2012. And falls within those 7-day rules. On the fee-for-service side, that's going to be paid under fee schedule and should be at least 5 minutes. If not at least 5 minutes, then that phone call is not billed. Next slide. Oh, I think my slide is frozen. Oh, there we go. Thank you. On the RHC side, the G0071 is the code that we assign for a virtual check-in. And so again, that is the code you'll want to have built in your system. The payment for that G0071 is really an average of the fee schedule rates for G2012 and G2010, which is that Part B code assignment. And the rules are the same. Again, patient initiated. The 7-day rule applies to the G0071. Another thing to keep in mind is that you don't bill more than one G0071 within a 7-day time period, even if those reasons for contact with a patient are unrelated. Medicare did not ever provide an exception for that rule. So you really just want to keep track of those patient-initiated calls to make sure those are being billed appropriately. Next slide. On the digital side, and these are our portal visits on the Part B side, there are specific CPT codes, and they are in the 99421 through 99423 category. And so again, this is your patient portal where the patient can access their own portal and communicate with the provider by usually email and communicate that way, basically to determine next steps. And that also falls within the 7-day rule. Next slide. And for the rural health clinic side, this is another service that even though it's through the portal and the CPT codes that you would assign are in the digital code range, that 99421 through 99422 those map over to the G0071. Just as you do for the e-checks, which is the patient-initiated triage call. So keep in mind the 7-day rules for that, and know that you should have those digital or e-check codes also loaded into your fee schedule side, because those codes are also used a lot on the Medicaid and on the commercial and MCO side as well. Next slide. The consents have really caused a lot of questions that we've had about where we need to get consents, where do they need to be. just the bottom line is, if this is a new patient that you're initiating a virtual communication with, you should probably obtain a consent. Medicare has allowed for that verbal consent that's at the point of service that you don't have to obtain prior to the service, but it's really best practice to make sure you have a consent, especially since there may be additional language that you have built into your information you need to obtain that informs the patient about the potential risk, because it is a virtual or electronic communication, all of the HIPAA information that needs to be shared with the patient, and that would be done if it was a new patient. So make sure you have that verbal consent, and that is in some way documented in your medical record. In some of the updates to Medicare, they have allowed now that if you have a waiver or a consent on the medical record for that patient, that includes those telehealth or remote services, and that's part of that form that you have completed once a year. And if that was maybe done, let's say at the beginning of 2021, all those forms were updated for your patients, that would be okay to have on file, and you would not have to access that at each point of service. But it's really going to be driven by maybe an established versus new patient, and when you might have obtained that last consent. Just make sure that's part of your thought process. In more circumstances, the nurses are obtaining that approval when they're kind of rooming, quote unquote, the patient at the beginning of that telehealth encounter before the provider gets online. So just wanted to update you on that as well. Next slide. The reimbursement for 2020 for G0071 in the RHC environment was $24.76. $24.76. And again, in 2021, we expect that dollar to go up just based on the adjustments that have been made on the fee schedule side. So stay tuned for what our reimbursement will be for the coming year. Next slide. Your other payers, we did not go in length to describe all the different payers, but suffice it to say that the way you're billing now for your Medicaid plan, your commercial payers, and your MCO payers is still appropriate. There have not been any changes to those billing guidelines since after maybe the middle of that, maybe March, April, May. I think May was the last that we really saw any adjustments or further clarification from any of the other payers on the billing guidance. So suffice it to say that through the end of the public health emergency, how we are billing our telehealth or virtual communication services to our payers will stay the same until the end of the public health emergency. And that includes use of any of those waivers or anything that we've had an exception on that we're now able to do that the payer would maybe not have covered or approved before the public health emergency. Those should also be in place. If not, you should have received a formal communication from that payer to that change in instruction. And to my knowledge, everybody is still holding on until there's congressional lifting of the public health emergency. So those guidelines should still be in place. Next slide. I really appreciate everyone's time. I really always enjoy speaking to all of you. And I know that telehealth and just the environment that we're working under has really been stressful. So we hope that this information is kind of beneficial as we move into the new year. And I'll shift it back to you, Shannon, to see if we have any questions.
Thank you, Marla. We haven't had anything come in yet, but please feel free to type in your questions, or remember, if you called in, it's *6 to unmute your phone line and ask a question. And while we're waiting for any questions, just a reminder that the slides and webinar recording from today's session will be available online following the 4-part bootcamp. Caleb will email them upon completion of the bootcamp. And if you wouldn't mind, Caleb, taking a moment, we'll pull up our post-poll questions.
Kind of had a trick question on there. That's mean. I shouldn't do that. I hated that when I was in school, but we still have some unknowns. So I think that was really the only that was what I was thinking when I put that into play.
All right, thank you, Caleb. Well, Marla, I haven't seen any additional questions come in, but if any do come in, I'll be happy to connect you with Marla. Again, BKD is offering those one-on-one coaching calls. So please reach out to me if that's something you feel like your team could benefit from. And thank you so much for your time today, Marla. And I look forward to seeing everybody next Tuesday.
All right, have a good day, everybody.
Thank you. Bye-bye.